Ladies and gentlemen, I'd like to welcome everyone to the Military Personnel Subcommittee hearing today on the Military Health System Overview and Defense Health Program Cost Efficiencies. And today, the subcommittee meets to hear testimony on the military health system and the Defense Health Cost Program for the fiscal year 2012. I'd like to begin by acknowledging the remarkable military and civilian medical professionals who provide extraordinary care to our service members and their families, along with veterans. Here at home and around the world, often in some of the toughest and most austere environments. I have recently returned from Balad and Bagram, where I am always appreciative of the professionals who have saved so many American, Iraqi, and Afghani lives. I have firsthand knowledge of their dedication and sacrifice from my second son, who has served in Iraq and is now an orthopedic resident in the Navy. But we are joint service. As a grateful dad, as a military family, I was reassured to the medical care available for my Army son and my Air Force nephew, who also both served in Iraq. The subcommittee remains committed to ensuring that the men and women who are entrusted with the lives of our troops have the resources to continue their work for future generations of our most deserving military beneficiaries. Even in this tight fiscal environment, the military health care system must continue to provide world-class health care to our beneficiaries and remain strong and viable in order to maintain that commitment to future beneficiaries. The Department of Defense has proposed several measures aimed at reducing the cost of providing health care to our service members and their families and military veterans. While I appreciate that your plan is more comprehensive approach than previous cost-cutting efforts, the challenge here is to find the balance between fiscal responsibility while maintaining a viable and robust military health care system. We must be sure to remember these proposals have complex implications that, quote, go beyond beneficiaries. They also affect the people who support the defense health system, such as local pharmacists, as healthcare employees at hospitals, and contractors. The subcommittee has a number of concerns about the Department's initiatives. To that end, we would expect the Department's witnesses to address our concerns, including, first, the proposed TRICARE Prime fee increase for the fiscal year 2012, while appearing to be modest, is a 13% increase over the current rate. DoD proposes increasing the fee in the out years based on an inflation index. You suggest 6.2%, but it is not clear which index you're using now and in the future. Second, you plan to reduce the rate that TRICARE pays the sole community hospitals for inpatient care provided to our active duty family members and veterans. Several of these hospitals are located very close to military bases. In fact, some are right outside the front gates, especially important for 24-hour emergency care. What analysis have you done to determine whether reducing these rates will affect access to care for our beneficiaries, and in particular, the readiness of our armed forces? I would also like our witnesses to discuss the range of efficiency options that were considered but not included in the President's budget. I would appreciate hearing your views on the recent GAO recommendations included in their report on federal duplication, overlap, and fragmentation. GAO made recommendations regarding establishing a unified medical command and for the DoD to finally jointly modernize their electronic health record system with the Veterans Administration. In addition, I would like to hear from the military surgeons about efforts they are taking within the military departments to increase the efficiency of the healthcare systems and reduce cost. I would also like the military surgeons' views on areas where additional efficiencies can be gained across the DoD health system. The Department of Defense, just last week, recently announced they've hired Governor John Baldacci, the former governor of Maine, to undertake a full-scale review of the military health care and the impacts of military health care on the forces. I would appreciate hearing from Dr. Stanley the considerations for this review and what the Department hopes to gain from Governor Baldacci's efforts. I'm concerned. First of all, I have faith in Dr. Stanley. He's a graduate of South Carolina State University, so I know of his capabilities. Why is having a military health care czar not a duplication of the duties already assumed by Undersecretary Stanley and Assistant Secretary Woodson? Finally, I would like to make it clear that in the effort to reduce the cost of military health care and find efficiencies in the military health care system, we must never lose sight of the population that the military medical system serves. The members of the armed forces and their families who currently serve and those who served as veterans for a full career in the past warrant the best health care system available. Reducing cost must never result in a reduced quality of the availability of health care they earned and they deserved. I hope that our witnesses will address these important issues as directly as possible in their oral statements and in the response to members' questions. Before I introduce our panel, let me offer our ranking member, who was a distinguished former chairman of this subcommittee, Congresswoman Susan Davis, an opportunity to make her opening remarks.
Thank you. Thank you, Mr. Chairman, and thank you for summarizing many of the issues that are before us today. I look forward to hearing from Undersecretary Stanley and Assistant Secretary Woodson on their views on the status of the military health care system, particularly the TRICARE program, and their efforts to improve the care that we are providing to our servicemen and women, retirees, survivors, and their families. Assistant Secretary Woodson, we welcome you. We're delighted that you're here. And I understand that it is your first testimony before the subcommittee. I'm pleased that the Senate finally confirmed you as the Assistant Secretary for Health Affairs. The Department is confronting many issues, and having you there is important if we are to be successful in facing those challenges. I also look forward to hearing from our Surgeon Generals, General Schoonmaker and Admiral Robinson. Thank you very much for your service, and I know that both of you, I believe, are retiring this year. So we will miss you. It has been a pleasure working with both of you over the past several years. The last 10 years of conflict have taken a toll on our forces and, in particular, those who serve in our military health care system. The constant demand on the system and the successes that we have seen both on the battleground and back home here in the States have been remarkable and a testament to your leadership. General Green, welcome back to you, sir. With the departure of General Schoonmaker and Admiral Robinson, of course, you will be the most senior Surgeon General, and I look forward to continuing to work with you. Well, I suspect that the majority of this hearing will focus on the Department of Defense's health care proposals that were included in the budget. This hearing will probably be one of the only hearings on health care that we will have prior to the subcommittee and committee markup. So as such, it is important that members of the subcommittee have an understanding of all the challenges that the military health care system is facing, not just the budgetary constraints. Our military personnel and their families are under constant pressure and challenges, and access to quality health care should not be on that list of concerns. I look forward to your testimony on how we are caring for our injured, ill, and wounded, and what can be done to continue to improve the military health care system. Thank you, Mr. Chairman.
Thank you, Ms. Davis. We have 5 witnesses today. We would like to give each witness the opportunity to present his testimony and each member an opportunity to question the witnesses. I would respectfully remind the witnesses that we desire that you summarize to the greatest extent possible the high points of your written testimony in 3 minutes. I assure you that your written comments and statements will be made part of the record. And of course, first we want to welcome the Honorable Dr. Clifford L. Stanley, the Undersecretary of Defense for Personnel Readiness, Dr. John Woodson, Assistant Secretary for Defense for Health Affairs, and this doctor I know is your first appearance, and we're delighted to have you here. And Lieutenant General Eric Schoonmaker, the Surgeon General, Department of the Army. And General, thank you for your distinguished career, and this is your last appearance, and we just wish you well in your future careers. And Vice Admiral Adam Robinson, the Surgeon General, Department of the Navy. And indeed, General Robinson, thank you, this too, I can see the big smile on your face, which means this is your last appearance here. And we appreciate your service, and thank you for, in every way, your service. And then soon to be the Senior Surgeon General, amazingly enough, the Lieutenant General Charles Bruce Green, the Surgeon General of the Department of the Air Force. And at this time, Dr. Stanley, you may begin.
Well, good morning, and thank you, Mr. Chairman and members of the committee. I really do appreciate this opportunity to appear before you today to discuss the future of the military health system, particularly our priorities for the coming year. Dr. Woodson, the Surgeon Generals, and I look forward to discussing our health care plans for 2011 and 2012. At the outset, I just want to acknowledge the performance and courage of our military medical professionals serving in combat theaters. For service members wounded in combat, their likelihood of survival after a medic arrives remains at historic and unmatched levels. For those seriously wounded service members who require months, years, and sometimes a lifetime of medical rehabilitation and treatment, we're committed to ensuring that they and their families receive the finest evidence-based medical services available in this country. And we are working ever more closely with our colleagues in the Department of Veterans Affairs to ensure our activities are better coordinated, to include the disability evaluation process, the sharing of personnel and health information, and collaboration on our future electronic health record. In addition to the efficiencies that we will discuss today, I've asked former Governor and former Representative John Baldacci, from Maine to help us work in a deep dive review of health care and wellness. Dr. Woodson and our Assistant Secretary of Defense for Health Affairs ensures that the military health care system runs smoothly every day, but I've asked the Governor to pursue a four-azimuth deep dive approach, which is focusing on readiness, improved health population, patient experience and care, and lastly, cost. And with that, I will turn to Dr. Woodson. But before I do that, I'd like to also thank the subcommittee for the tremendous support you provide the Department for our service members and their families, particularly the military health system. Thank you.
Next, we have Dr. Woodson.
Mr. Chairman, Ranking Member Davis, and members of the committee, thank you so much for this opportunity to appear before you today. I will briefly elaborate on Dr. Stanley's opening statement. I have had the privilege of serving the military health system both in uniform as an officer and physician and in my current role as Senior Medical Advisor to the Secretary of Defense. This system has shown time and again that it is a vibrant learning organization capable of self-improvement and rapid incorporation of lessons learned into both our combat and peacetime endeavors. In our combat theaters, Dr. Stanley has already noted the historic rates of survival among those who are injured. I would also point out the reductions in disease and injuries through improved public health and preventative medicine strategies. Thanks to the ongoing support of Congress, we are continuing to invest deeply in medical research and development on the most challenging medical issues we are confronted with from the war. We are accelerating the delivery of our scientific findings from the laboratory to the bench to the battlefield to include prevention, diagnosis, and treatment for both visible and invisible wounds of war. We are also making important investments in how we deliver care to all of our beneficiaries. The patient-centered medical home is a transformative effort within our system. We have enrolled more than 655,000 beneficiaries to date, with promising results in the use of preventative services, reducing emergency room use, and provision of more timely care. In addition to our investments in readiness, improved population health, and improved service to our patients, we also have proposed some changes that will allow us to more responsibly manage our costs. Our efficiency initiatives share the responsibility for cost controls among all of the participants, including us internally at Health Affairs and TMA, among provider communities, and with our beneficiaries for whom we proposed a very modest change to select out-of-pocket costs. Throughout our proposals, we have taken steps to protect those who are enrolled in existing programs or who have special circumstances that must be considered and protected. Our proposed budget helps keep fidelity with our core principles. We will never lose our focus on our commitment to all of the men and women who serve in the armed forces, their families, those who have served in the past and present, and those who will serve in the future. We are proud to represent the men and women who comprise the military health system, and we look forward to your questions this morning.
Thank you very much. And General Schoolmaker.
Chairman Wilson, Ranking Member Davis, distinguished members of the committee, thanks for permitting me to talk with you today about the dedicated men and women of the Army Medical Department who bring value and inspire trust in Army medicine. Despite over 9 years of continuous armed conflict, for which Army medicine bears a heavy load, every day our soldiers and their families are kept from injuries, illnesses, and combat wounds through our health promotion and prevention efforts, and are treated in a state-of-the-art fashion when prevention fails, and are supported by an extraordinarily talented medical force, including those who serve at the side of the warrior on the battlefield. We're a member of this military health system team committed to partnering with soldiers, families, veterans to achieve the highest level of fitness and health for all. We've been leaders in innovation for trauma care and preventive medicine that have saved lives and improved the well-being of our warriors, and improvements that have really changed even clinical practices in the civilian sector. We are focused on delivering the best care at the right time and place. I'd like to talk about our work through the lens of 5 E's: enduring, early, effective, efficient, and in an enterprise fashion. We have an enduring commitment to care through initiatives such as the Warrior Care and Transition Plan and the Soldier Medical Readiness Campaign Plan. We have an enduring responsibility alongside our sister services in the Department of Veteran Affairs to provide care and rehabilitation for wounded, ill, and injured for many, many years to come. We have a Warrior Transition Command in the Army Medical Department under the leadership of Brigadier General Darrell Williams. Many of you have met him. He's a key in our provision of care and provides a centralized oversight for the Army's Warrior Care and Transition Program. Our focus is on investing soldiers and families with dignity, respect, and self-determination to successfully reintegrate them either back into the force or into the community. Since we stood up the first Warrior Transition units in June of 2007, more than 40,000 wounded, ill, and injured soldiers and their families have either progressed through or are currently in care, and we've returned over 16,000 soldiers to the force. We've also created a Soldier Medical Readiness Campaign that has been brought about because of the rising cost of health problems in our force, especially within the reserve components. Among its many goals, under the leadership of Major General Rich Stone, a mobilized reserve component physician from Michigan, they are to identify the medically non-ready soldier population and implement medical management programs to reduce this medically non-ready population with an ultimate end state of a deployment of a healthy, resilient, and fit soldiers and increase Army medical readiness. Those soldiers that can no longer meet retention standards have to navigate our physical disability evaluation system. Assigning disability has long been a contentious issue. DoD and VA have jointly designed a new disability evaluation system that integrates the DoD and VA processes with the goal of expediting the delivery of VA benefits to service members. This pilot, called the Integrated Disability Evaluation System, or IDES, began in late 2007 at Walter Reed. It's now in 16 of our Army medical treatment facilities, and it will be the DoD and VA replacement for the legacy disability evaluation system. But even with this improvement, disability evaluation remains complex and adversarial. Our soldiers still undergo dual adjudication, where the military rates only an unfitting condition and the VA rates all service-connected conditions. Dual adjudication is confusing to soldiers. It leads to serious misperceptions about the Army's appreciation of the wounded, ill, and injured soldier's complete medical and emotional situation. And IDES has not changed the fundamental nature of the dual adjudication process. Under the leadership of the Army Chief of Staff of the Army Chief of Staff and the Army G1, we continue to forge the consensus necessary for a comprehensive reform of the physical disability evaluation system, in which the Army and the DoD only determines fitness for duty and the VA determines disability compensation. Our second strategic aim is to reduce suffering, illness, and injury through early prevention. Army public health protects and improves the health of the Army community through education, promotion of healthy lifestyles, and disease and injury prevention. The health of the total Army is essential for readiness, and prevention is the key to health. Examples of this are the promotion of healthier lifestyles, achieving the highest measures of population health measured by HEDIS, implementation of the patient-centered medical home that you've heard about already, and I hope you'll hear more about, and the focus on, for example, body mass index and childhood obesity. The Army is leading the way also in the recognition and treatment of mild traumatic brain injury or concussion through an educate, train, treat, track strategy. Our Vice Chief of Staff of the Army, Pete Corelli, has led personally in this, and we've refined this through General Richard Thomas, my Assistant Surgeon General for Force Projection. We fielded this program, which some have called the CPR for the brain, increasing the awareness and screening of concussive injury and leading to a decrease of the stigma associated with seeking care. The use of evidence-based practices are aimed at the most effective care is our third strategic aim. For example, we've harvested the lessons of almost a decade of war and now strengthen our soldiers' and families' behavioral health and emotional resiliency through a campaign that aligns all of the behavioral health programs within this human dimension of the Army's force generation cycle. We call this the Comprehensive Behavioral Health System of Care. We've got now outcome studies that demonstrate the profound value of using multiple touch points in assessing and coordinating health and behavioral health for soldiers and families across this cycle. Coupled with the major advances in battlefield care under the Joint Theater Trauma System, which was birthed in the Army's Medical Research and Material Command and the Army's Institute of Surgical Research, we've made great strides in preventing and managing physical and emotional wounds of war. Additionally, we've launched a comprehensive pain management strategy to address chronic pain that our soldiers focus. It's holistic, multidisciplinary, multimodal, utilizes art, the state-of-the-art care, and it's focusing on non-pharmacologic practices such as incorporating complementary and alternative therapies like acupuncture and massage therapy, movement therapy, yoga, and other mind-body medical practices. Our fourth strategic aim is optimizing efficiencies that you've alluded to. We do that through leading-edge business processes and partnerships with the other services and veterans organizations. Ultimately, I'd like to say that the principal efficiency and cost-saving step in healthcare is the maintenance of health, promotion of good health, and the focus on good clinical outcomes and evidence-based practices. But we're also working with the DoD and the VA to create a single electronic health record, seamlessly transferring patient data between and among the partners to improve efficiencies and continuity of care. We share a significant amount of health information today. No two health organizations in the nation share more non-billable health information than the DoD and the VA. The departments continue to standardize this sharing activity and are delivering information technology solutions that will significantly improve the sharing of appropriate electronic health information. Our fifth aim is an enterprise approach. We've re-engineered Army medicine, we've created a public health command, and we've re-engineered our regional medical commands to align with the TRICARE region so that we can more efficiently provide health care in a seamless way through our TRICARE partners. We also have at each regional medical command a deputy commander who's responsible for readiness and can reach out even to our reserve component elements within their area of responsibility to ensure that all medical and dental services are being provided and our reserve units are optimally ready. This is my last congressional hearing cycle as the Army Surgeon General and the Commanding General of the Army Medical Command. I'd like to thank the committee for the opportunities I've been given to highlight the accomplishments we've made, the challenges we face, to hear your collective perspectives regarding the health of our extended military family and the health care we provide. I've appreciated your tough questions, your valuable insights, the sage advice you've offered, and the deep commitment you've all demonstrated to our soldiers and their families. On behalf of over 140,000 dedicated soldiers, civilians, contractors that make up my command in Army medicine, I'd like to thank also the Congress for your continued support and providing the resources we need to delivering leading-edge health services and build healthy and resilient communities. Thank you.
General Schoomaker, thank you very much, and thank you for being so candid. And Admiral Robinson, again, I'm so grateful for the briefing you provided at your very historic office. And so thank you for coming by today.
Thank you very much, Mr. Chairman. Chairman Wilson, Congresswoman Davis, distinguished members of the subcommittee, I'm pleased to be with you today and want to thank the committee for the tremendous confidence and unwavering support of Navy medicine, particularly as we continue to care for those who go in harm's way, their families, and all beneficiaries. Force health protection is the bedrock of Navy medicine. It is what we do and why we exist. It is our duty, our obligation, and our privilege to promote, protect, and restore the health of our sailors and Marines. This mission spans the full spectrum of health care, from optimizing the health and fitness of the force to maintaining robust disease surveillance and prevention programs to saving lives on the battlefield. I, along with my fellow surgeons general, traveled to Afghanistan last month and again witnessed the stellar performance of our men and women delivering expeditionary combat casualty care. At the NATO Row 3 Multinational Medical Unit, Navy Medicine is currently leading the joint and combined staff to provide the largest medical support in Kandahar with full trauma care. This state-of-the-art facility is staffed with dedicated and compassionate active and reserve personnel who are truly delivering outstanding care. Receiving 70% of their patients directly from the point of injury on the battlefield, our doctors, nurses, and corpsmen apply the medical lessons learned from 10 years of war to achieve a remarkable 97% survival rate for coalition casualties. The Navy Medicine team is working side by side with Army and Air Force medical personnel and coalition forces to support U.S. military, coalition forces, contractors, Afghan National Police, Army, and civilians, as well as detainees. The team is rapidly implementing best practices and employing unique skill sets such as an interventional radiologist, pediatric intensivist, hospitalists, and others in support of their demanding mission. I am proud of the manner in which our men and women are responding, leaving no doubt that the historically unprecedented survival rate from battlefield injuries is the direct result of better trained and equipped personnel in conjunction with improved systems of treatment and casualty evacuation. We spend a lot of time discussing what constitutes world-class health care. I would like to be clear that there is no doubt in my mind that the trauma care being provided in theater today to our casualties is truly world-class, as are the men and women delivering it. Their morale is high and professionalism unmatched. We also had the opportunity to visit our Concussion Restoration Care Center at Camp Leatherneck in Helmand Province. The center, which opened last August, assesses and treats service members with concussion or mild TBI, mild traumatic brain injury, and musculoskeletal injuries, with the goal of safely returning to duty many service members as possible to full duty following recovery of cognitive and physical function. The CRCC is supported by an interdisciplinary team including sports medicine, family medicine, mental health, physical therapy, and occupational therapy. The CRCC, along with other programs like OSCAR, our Operational Stress Control and Readiness Program, in which we embed full-time mental health personnel with deploying Marines, continues to reflect our priority of positioning our personnel and resources where they are most needed. We have no greater responsibility than caring for our service members, wherever and whenever they go. We must understand that preserving the psychological health of service members and their families is one of the greatest challenges we face today. We recognize that service members and their families are resilient at baseline, but the long conflict and repeated deployments challenge this resilience. We also know that nearly a decade of continuous combat operations has resulted in a growing population of service members suffering with traumatic brain injury. We are forging ahead with improved screening, surveillance, treatment, education, and research. However, there is still much we do not yet know about these injuries and their long-term impact on the lives of our service members. I would specifically point out that the issuance of the directive-type memorandum in June 2010 has increased line leadership awareness of potential traumatic brain injury exposure and mandates post-blast evaluations and removal of blast-exposed warfighters from high-risk situations to promote recovery. We also recognize the importance of collaboration and partnerships, and our efforts include those coordinated jointly with the other services, the Department of Veterans Affairs, the Centers of Excellence, as well as leading academic and research institutions. Let me now turn to patient and family-centered care. Medical Home Port is Navy Medicine's patient-centered medical home model, an important initiative that will significantly impact how we provide care to our beneficiaries. Medical Home Port emphasizes team-based, comprehensive care and focuses on the relationship between the patient, their provider, and the healthcare team. Critical to its success is leveraging all of our providers and supporting information technology systems into a cohesive team that will not only provide primary care, but integrate specialty care as well. We continue to move forward with the phased implementation of Medical Home Port at our medical centers and family practice teaching hospitals, and initial response from our patients is very encouraging. Both force health protection and patient and family-centered care are supported by robust research and development capabilities and outstanding medical education programs. These are truly force multipliers. The work that our researchers and educators do is having a direct impact on the treatment we are able to provide our wounded warriors and helping to shape the future of military medicine. Finally, I would like to address the proposed Defense Health Program cost efficiencies. Rising health care costs within the MHS continue to present challenges. The Secretary of Defense has articulated that the rate at which health care costs are increasing and relative proportion of the Department's resources devoted to health care cannot be sustained. He has been resolute in his commitment to implement systemic efficiencies and specific initiatives which will improve quality and satisfaction while more responsibly managing costs. The Department of the Navy fully supports the Secretary's plan to better manage costs moving forward and ensure our beneficiaries have access to the quality care that is the hallmark of military medicine. In summary, I am proud of the progress we are making, but not satisfied. We continue to see groundbreaking innovations in combat casualty care and remarkable heroics in saving lives. But all of us remain concerned about the cumulative effects of worry, of stress and anxiety on our service members and their families brought about by a decade of conflict. Each day resonates with the sacrifices that our sailors, Marines, and their families make quietly and without bravado. It is this commitment, this selfless service, that helps inspire us in Navy medicine. Regardless of the challenges ahead, I am confident that we are well positioned for the future. Since this is my last cycle of hearings, I too would like to extend my sincere appreciation to the committee and the members and the professional staffers for all of the support, the insights, and the advice being given. It has been a true honor being before you and actually working with you. I appreciate the opportunity to be here today and look forward to your questions. Thank you very much.
Admiral, thank you very much. And General Green?
Good morning. Mr. Chairman, Representative Davis, and distinguished members of the committee, I appreciate the opportunity to meet with you today representing the men and women of the Air Force Medical Service. We could not achieve our goals of better readiness, better health, better care, and best value for our heroes and their families without your support, and we thank you. Military health system achievements have changed the face of the war. We deploy and set up hospitals within 12 hours of arrival anywhere in the world. We move wounded warriors from the battlefield to an operating room within minutes and have achieved and sustained a less than 10% died of wounds rate. We move our sickest patients in less than 24 hours of injury and get them home to loved ones within 3 days to hasten recovery. We have safely evacuated more than 85,000 patients since October 2001. 11,300 in 2010 alone, many of them critically injured. The Air Force Medical Service has a simple mantra: trusted care anywhere. This fits what we do today and will continue to do in years ahead. It means creating a system that can be taken anywhere in the world and be equally as effective, whether in war or for humanitarian assistance. Medics at Air Combat Command have now developed an EMEDS deployable hospital that's capable of seeing the first patient within 1 hour of arrival and performing the first surgery within 3 to 5 hours. These systems are linked back to American quality care and refuse to compromise on patient safety. Providing trusted care anywhere requires the Air Force Medical Service to focus on patients and populations. Patient-centered care builds new possibilities in prevention, by linking the patients to provider teams that both the patient and the provider can be linked to an informatics network dedicated to improving care. Efficient and effective health teams allow recapture of care in our medical treatment facilities to sustain currency, and continually improving our readiness ensures patients and warfighters always benefit from the latest medical technologies and advancements. The Air Force supports the DoD strategy to control health care costs and believes it is the right approach to manage and benefit while improving quality and satisfaction. By the end of 2012, Air Force Patient-Centered Medical Home will provide 1 million of our beneficiaries new continuity of care via single provider-led teams at all of our Air Force facilities. We will do all in our power to improve the health of our population while working to control the rising costs of health care. The Air Force Medical Service treasures our partnerships with OSD, the Army, Navy, Veterans Administration, civilian and academic partners. We leverage all the tools you have given us to improve retention and generate new medical knowledge. We will continue to deliver nothing less than world-class care to military members and their families, wherever they serve around the globe. Thank you, and I look forward to answering your questions this morning.
Thank you very much, General. And as we begin questions, I want to make it clear we're going to have a 5-minute rule, and it first of all applies to me. And we have someone very impartial who's going to be observing this and monitoring it, Jeanette James. And so, Ms. James, on the mark, get set, go. With this in mind, indeed, Dr. Stanley, knowing your background, your military background, medical, and Dr. Woodson, I have faith in both of you, and I have faith in both of you as to the oversight of military health care. And so it was a real surprise to me that out of the blue last week there would be a military health care czar appointed, Governor Baldacci, former governor of Maine. And I understand he's to conduct a 1-year review. I truly believe that that's a duplication, and the General Accountability Office just 2 weeks ago said that our government suffers from duplication, overlap, fragmentation, and then in light of that, a new position is created at a time where we're all concerned about efficiencies, and now we're adding a new job, I believe, $163,000 a year. That just doesn't seem right to me. And then I'm also concerned, in light of this study, why should Congress enact what you're proposing, which are the defense health cost efficiencies, if this work could be overturned by another major reform by another party?
Well, first of all, Congressman and Chairman, I thank you, first of all, for your confidence.
Absolutely.
Because the efficiencies that we're talking about today, and specifically, are decoupled and are not directly related to what Governor Baldacci is going to be doing. His charge by me, because I asked him, I first of all wanted to have an objective outside look. I've looked at GAO reports. My charge from Secretary Gates when I first joined the department last year was to look at P&R a little differently. We have not really been as open as I think we should have been with VSOs. I don't think we've been as open as we should have been in terms of following some of the things that have been laid down before in terms of recommendations. I needed an outside look, and I had a member of Congress, as well as a former governor now, who served 2 terms, to help with not only Guard and Reserve issues, but also looking at the holistic viewpoint of readiness, of wellness, of looking at how we're going to do patient satisfaction, and then cost was the last piece. So the duplication is not what I've actually see right now. Actually, I'm asking Dr. Woodson to work very closely with him as we look at the objective assessment of this.
And Dr. Woodson?
Thank you for that question. I think in part with the delay in my confirmation and sort of the inconsistent leadership within health affairs, there was a need to, in fact, look at how business was conducted within health affairs. I do not see the governor's mandate as interfering with my statutory authorities and the efficiencies that we need to roll out. To the extent that Governor Baldacci conducts his studies and produces products that informs me in terms of what additional reforms need to be made, I look forward to his work.
I'm concerned too, and I'm glad you brought up about confirmation. I don't believe this position goes through confirmation. That concerns me. General Schoonmaker, real quickly, with the it's so important about the Walter Reed Bethesda, what I consider to be merger, but I'm very concerned about the level of support provided for the wounded warriors. Will it be equal to what we know is world-class currently at Walter Reed?
Well, sir, we've worked, I think all the services have worked very, very hard to ensure that that's going to occur. We've had some very, very tight schedules and some unexpected hurdles that we're going to have to overcome. I feel that I should say honestly that there are going to be some patients and some clinical situations in a new system that is going to be, who are going to be facing unfamiliar terrain. We're going to have a new physical plant, new organizational arrangement, and a new virtual space, that is the electronic health record, to deliver that care. But I can say that we're working as hard as we can to meet those both the deadlines as well as the standards of high quality care.
Thank you. And with the 5-minute rule, Ms. Davis.
Thank you. Dr. Stanley, I understand that the Department analyzed a number of options before it considered what proposals to put forward to try and address the growing health care budget. So I wondered if you could share with the subcommittee what other proposals were considered and subsequently rejected by the Department.
Yes, Congresswoman Davis. The Department did, in fact, look at other options, everywhere from curtailing certain studies, doing curtailment on research, dealing with not only cancer research, but looking at a whole range of options. I know that I'm going to ask Dr. Woodson to help with some of this, but bottom line is that over the years before I came, there were actually higher costs looked at, which were rejected not only by this body, but also internally looking at ways to be more efficient, but also having minimal impact or effect on our troops and affecting our active duty component. So we looked at things that would have minimal impact on active duty, and at the same time not really affecting even our retirement community or reserve and guard significantly, just looking at ways to manage costs but still deliver quality care. And that's where we came down with these minimal efficiencies that we're looking at.
Dr. Woodson, did you?
Thank you very much for that question. Producing efficiencies and reduction in cost in health care is an ongoing effort, both within the military health system and within civilian sector as well. Since 2007, $1.65 billion have been saved in the military health system by introducing mail-order pharmacy products, going after federal price ceiling, using outpatient prospective payment systems, enhanced fraud detection, and standardizing medical supplies and equipment. And of course, I would remind the committee that the factors that are influencing the rise in health care include the fact that we have an increased number of users, new products, and we have growing pharmacy use and growing utilization of healthcare resources. Now, we have endeavored to streamline our practices and produce efficiencies. We mentioned the patient-centered home as a method for particularly managing chronic disease, which reduces cost but also improves quality of care. We've undergone consolidation and initial outfitting and transition of equipment efficiencies. We centralized procurement of medical equipment and devices. We've also reduced service contracts, and we continue to look at this as a source of efficiencies. And as you know, we're undergoing an efficiency evaluation to reduce 780 FTEs from health affairs and TRICARE management activity. We streamlined TMA, TRICARE management activity operations, and expanded the use of urgent care and nurse advice lines to produce better quality of care and more efficient care. So there have been a number of initiatives that have been implemented, continue to be implemented. And again, I would remind the committee that between 2001 and 2008, the rise in cost of health care was about 11.8% per year. We are really desperately trying to bend that curve and produce all sorts of efficiencies, and that's why we've considered for FY12 a really balanced approach to bending that cost curve. Thank you.
I appreciate your response, and one of the things I was wondering about the Surgeons General. Could you just talk a little bit about the engagement of this of you all, and whether you felt that there was adequate opportunity for people to weigh in on these issues? Admiral, did you want to?
Yes, Congresswoman Davis. I think that the Surgeon Generals, all of us have been brought into the whole efficiency movement. I think that coming from health affairs, we've all been tasked to look not only at what we're doing externally with the 5 efficiencies that have been named, but also the internal approach. And it has been through, in my opinion, the medical home where all 3 services leverage some of the efficiencies that are occurring in terms of access to care for primary care, integration of specialty care, having a real provider-patient relationship 24 hours, 7 days a week, decreasing urgent and emergency room visits, and having the ability to emphasize prevention rather than disease care. So in the medical home port model, what the Navy calls, the same model that the medical home is what Air Force and Army uses also, I think that it is going to be one of those major efficiency moves in terms of quality of care. Yes, ma'am.
I think my time is up. General, perhaps later we'll have a chance for your response.
And thank you very much. Congressman Jones of North Carolina.
Mr. Chairman, thank you very much. And my question will be directed to Admiral Robertson and General Schoonmaker. I want to thank you first for your service and the many times you've testified and the fine work you've done for our military. Like most members of Congress, I visited Walter Reed and Bethesda on a regular basis, and I make reference to this article of March 9th. Report reveals steep increase in war amputations last fall. And it seems like the last year that I have had the privilege to visit the heroes at Walter Reed and Bethesda, that the severity of the wounds are deeper or more severe than ever. One being a kid that lost most of his lower body parts. The other being a sergeant first class who on 4th tour in Afghanistan, as he told me that day, that he's always told the young Marines to walk in the boot print in front. He did and blew his leg off, and other parts of his lower body were injured. My concern for those who are still in the military who are severely wounded, as well as when they leave the military, but this panel today, and that's why I single out the Admiral and the General for this answer. Are you satisfied that we are where we need to be as it relates to psychiatrists in the Army and the Navy? Do we have an issue there that the government needs to really reach out and try to encourage those who are graduating from the schools who are getting degrees in psychiatry to look more at trying to come into the military, or do you feel like the numbers are where they need to be? My concern is, I'm going to let you answer in 1 second. My concern is not only the young injured, but if they have a mom or dad, or if they have a wife and children. My concern is that I want to make sure that they get the mental health care as well as the physical health care. General, I'll go to you first and then the Admiral second.
Well, mindful of the time, sir, I'm going to say 2 things real quickly. First of all, not to minimize or in any way to marginalize the interest that you have in this complex injury pattern that you've seen. We've recognized the same thing. In fact, I started up a task force a month or so ago to look in greater detail under the leadership of Brigadier General Joe Carvalho from the Southern Region Medical Command and Brooke Army Medical Center. He's pulled a team together to look at the data and look at the magnitude of the injuries that we're now seeing. We're seeing a larger number, as you've seen, of complex injuries from dismounted operations in Afghanistan, with more multiple limbs lost and higher limbs with abdominal and genital injuries as well. We think this is the dark side of a good story. Soldiers and Marines are surviving even more than they have in the past. Battlefield medicine is improving in all facets, but what we get is a soldier or Marine, sailor, airman who's very, very severely injured, and we are focusing now on what we need to do for them. As far as psychological care, this is a moving target. We've seen, as Dr. Woodson talked about, an increasing utilization, especially in behavioral health, across all of our units and families. We've increased the number of behavioral health specialists, not just psychiatrists, but social workers, psychologists, our nurse psychiatric workers, as well as our enlisted. The Army's allowed us to put more of them down into battalions and brigades. We continue to chase that. We are not satisfied. As you pointed out, the need is still there.
Admiral.
The entire nation has a real challenge with behavioral health needs. The military certainly has an even increased challenge. I would say that what General Schoonmaker said is correct. I would ditto everything that he has said. We don't have enough psychiatrists, psychologists, social workers, or nurse practitioners in the sense that I can always use more. If we look at the retention rates, particularly with psychiatry, we're probably in Navy at 72%. With that said, we have spent about $240 million in contracts. We have now about 144 more behavioral health contractors at 14 of our MTFs. We have billeted for an increase in social workers from 35 to about 86, which is a substantial increase. We are looking at each facet of behavioral health, who we have, where they are located, and how we use them. We also put them, and we embed our mental health professionals with our operational stress control, our OSCAR teams. We put them with the deploying units so that we can get care to people that they need immediately. On the home front, we have focus or families overcoming under stress. It's a focus, the program is called, in which we look at families and their behavioral health needs and the needs of the children, the spouses, et cetera. So we're putting together, I think, across the military health system, a comprehensive look. Is it enough? It's all that we have now. We can always do better, and this is the major challenge, as I said in my opening statement, a continuing major challenge. It really is a moving target. We're trying to stay with it, and we will never leave those men and women behind.
Thank you, sir. Thank you, Mr. Chairman.
Thank you. And a good story. In January, I visited a young injured Marine, Corporal Kyle Carpenter, and Kyle has had dozens of operations. He was gruesomely injured, and he last week was on the front page of the newspapers across South Carolina, appearing at the South Carolina Senate, where he was on the floor, and all the members of the Senate welcomed him and shook his hand, and he was given heroes deserve welcome. Congresswoman Nikki Tsongas of Massachusetts.
Thank you all for being here, and I have to say I share Congressman Jones' concern, but I too have a good story. Last week I visited a young first lieutenant in the Army who had been injured by an IED in Afghanistan. He had sadly lost the lower portion of his leg, but he was on a good recovery. Yet another example of a very determined young man who wants to make the best of his service to our country and to the life that lies before him. So I thank you all for the great work that you are putting in challenging times. But I also wanted to start out by commenting on the Uniformed Services Family Health Plan. The U.S. FHP had its genesis 30 years ago when the direct care system needed help to meet the health care needs of our military personnel, retirees, and dependents. And since then, as you all know, they have become the highest rated health care program in the military health system based on beneficiary satisfaction, with a 90.4% satisfaction rate in 2009. Their approach to patient care management, with a focus on prevention and a continuum of care, has improved clinical outcomes, decreased emergency room visits, and hospital admissions. This health plan is a model for what we have been aiming to do as we all struggle with the rising cost of health care. So I would urge that as a body, we give careful analysis to the impact of your proposals to shift its cost to Medicare for retirees. Simply a statement of concern. But I have a question, Secretary Stanley and Dr. Woodson. Secretary Gates has stated that, quote, health care costs are eating the Defense Department alive, unquote. And according to the U.S. News and World Report, health care costs as part of the defense budget have gone from $19 billion in 2001 to about $55 billion now, about a tenth of the total. Currently, the over 2 million military retiree families enrolled in the lifetime health insurance system, TRICARE, pay $460 per family per year for health insurance, and an individual pays $230 per year. As we all know, these fees have not been raised in 15 years. With this in mind, I do believe that Congress needs to take on the difficult task of reviewing this fee structure. It's an issue that will have to be dealt with because of the massive strain which has been placed on the defense budget by rising health care costs. However, I believe it must be done in such a way as to minimize its impact. It would be inexcusable to deprive our retired heroes of the health benefits they have earned. For active duty personnel, the Department has different annual deductible rates for TRICARE Extra and TRICARE Standard on the basis of pay grade. For example, under TRICARE Standard, the deductible is $150 per individual or $300 per family for beneficiaries at E5 and above, and $50 per individual or $100 per family if the beneficiary is under E5. Retirement benefits vary greatly depending on how long a person served and at what rank they retired. One of the more significant changes made by the National Defense Authorization Act for fiscal 2000 was the lifting of the 75% cap used in the calculation of retired pay for members eligible for service retirements. Under this calculation, a retired O10 with 45 years of service could earn over $210,000 per year before taxes in retirement. But an E5 with 20 years of service would earn only around $17,000 in annual retirement pay before taxes. Keeping this great gap in benefits in mind, I'd like to ask, has the Department seriously reviewed any proposals for a stepped increase of TRICARE prime fees determined on the basis of rank at the the time of retirement and retiree benefits earned?
Congresswoman Tsongas, thank you very much for the question. I'm not aware of stepped increase. Look, the amount that was chosen was considered really a minimalist approach to addressing probably a long-standing issue of just prices just not changing or costs or charges being put onto the beneficiaries. Dr. Woodson, I'm not sure if you've heard anything on that. I haven't.
Thank you, Dr. Stanley. Thank you for the question. I agree that we haven't looked at stepwise increases because we've introduced very modest changes. And as an administrative process, it becomes more difficult to assess income and who should have the stepwise increase because, in fact, even an enlisted person who retires after 20 years may actually enter a very good paying job, and so what they actually make may not always relate just to their retirement pay. And I would just remind the committee members to reflect on the fact that our proposal suggests modest increases for working age retirees, and so we would probably have to means test against the issue of what their total salaries are. It's conceivable that following retirement, as talented as our men and women are who serve, they contribute greatly, get advanced degrees, and may be doing quite well. So administratively, it would be very tough to means test. If we were proposing large fee increases, I would agree with you strongly.
Thank you.
Thank you, Ms. Tsongas, and we're very grateful to have distinguished freshmen on the committee. The first is Dr. Joe Heck of Nevada. He is actually a staff alumnus of the Uniformed Services University of Health Sciences.
Thank you, Mr. Chairman. And Dr. Stanley, Dr. Woodson, Surgeons General, thank you for being here today, and thank you for your commitment to our servicemen and women's health and the health of their families. I'm going to refer to the joint written statement of Dr. Stanley and Dr. Woodson, specifically reserve health readiness. You referenced the individual medical readiness metric that's been developed. And in your statement, you quote, "Within the reserve component, medical readiness is below our benchmarks," end quote. And of course, this is an area of great concern for me, and it raises several issues that I'd like to bring up, revolving primarily around the LHI contract and how that service is currently performed for the Army Reserve. You know, as you well know, we have units in the Army Medical Reserve, MSUs, Mobilization Support Units, whose job it is to accomplish the medical aspect of soldier readiness processing when they get mobilized to their support base. However, they are prohibited from performing that very same service for their own reserve counterparts on a BTA weekend. In your notes, you mention issues with minor dental procedures and immunizations being an issue that can be readily fixed in pre-mobilization or pre-deployment mobilization. Yet, in my unit, I have dentists that on a BTA weekend can go out and provide services to homeless people as a community service, but can't examine the reservists that are in their own unit because it's prohibited because of the LHI contract. In immunizations, every fall, our immunization readiness plummets because the new flu vaccine comes out and everybody's compliance falls off until everybody gets their flu vaccine. You would think that in a medical unit full of doctors, nurses, and medics, we could immunize each other. But we can't even get the vaccine because we have to put in a voucher for LHI to come and do the immunizations. The issues here are multiple. One, as you well recognize, it impacts our medical readiness. Two, it impacts our ability to perform real-world training. Certainly our docs and nurses are doing that in their day job. But my 68 whiskeys, my combat medics, they could be a janitor, they could be a garbage man, they could be a school teacher, and we're taking away an opportunity for them to actually do their medical training on a drill weekend. We send people to a PHA, we send soldiers that are well, and they come back to us broken. They go in well and they come back with a P3 profile. They are now medically non-deployable. And it takes us 6 months or more to backtrack and get that profile lifted because the folks doing these physicals don't understand what the profile process is. I'm encouraged by Major General Kasulki at AR Medcom, who's starting a pilot project to review all these things and trying to find a way to take care of these missed profiles. But the answer is not to have the person come back broken to begin with. So my questions are, I understand that the LHI contract is up for renewal. I'd like to know who is the formal approval authority for that contract. Is the Army considering any other options or modifications to the contract? What is the overall cost? And how can we document whether or not that LHI contract has provided any value-added service to our medical readiness?
Thank you, Congressman, for that very good question. And I would like to take that one for the record and get back to you with the substantive facts and answer you specifically. I think it probably is time for a review as we look at individual medical readiness and seeing how we can get added value out of all of the contracts that we employ.
I appreciate that, and I think it's critical that we also look at the opportunities to allow, I mean, back in the old days, and I guess for the record, I should probably disclose the Honorable Woodson used to be my raider when he was Brigadier General Woodson at AR Medcom. And I thank you for all those good ratings, sir. You know, we need to get back to the point where our Army Reserve medical personnel can do medical stuff on BTA weekend and maintain their skills. In the old days, we used to do all the physicals. And then all of a sudden there was an LHI contract and we were prohibited from doing those same things that we did for decades. So I look forward to the answers for the record, sir. Thank you.
Congressman, if I could just make one comment, I think what you described also is why we stood up this Soldier Medical Readiness Campaign under a mobilized reservist, Rich Stone, and I'd welcome an opportunity to have him come out and talk to you about that and what we're trying to do in partnership with both the Guard and Reserve.
Thank you, General. I appreciate that.
Thank you very much. And the issues that we're dealing with are so important for our service members, families, and veterans. In council, we'll do a second round of one question each. But at this time, we immediately, of course, go to Ms. Pingree of Maine.
Thank you very much, Mr. Chair, Secretary Stanley, Dr. Woodson, and all of the Surgeon Generals. I really appreciate your service to our country, your testimony this morning, and so much of what you've been talking about are things that I appreciate hearing about, whether it's how you treat traumatic brain injury or using alternative methods of care to find more ways to heal our soldiers, talking about the medical home concept. There's so many good things that you're doing, and I appreciate it, and I appreciate all the work that you've done. And I understand Chair Wilson's concern about the recent appointment of the governor from my state, Governor Baldacci, and his interest in making sure we're doing everything that's as cost-effective as possible. But I do want to just say that Governor Baldacci has a great work ethic. He's very devoted to our military, and he's worked very closely with the National Guard in our state to improve many of the practices in our state. So I look forward to him looking for some of the efficiencies that could be found. But I want to reiterate some of what my colleague from Massachusetts talked about earlier. It is a deep concern for me. I represent the state of Maine, and I'm proud to represent many active duty members and their families as well as military retirees and their families. I have over 34,000 military families and retirees that are fortunate to have access to outstanding health care provided by U.S. Family Health Plan at Martins Point Healthcare in Maine. I visited their facility. I've seen their use of the medical home model of care. The beneficiaries tell me how much they like this health care option. I mean, it's been said many times, this is exactly where we want to go with health care with our military retirees, and they are very happy, very satisfied about it. In March, I sent a letter to you stating my unequivocal support of how this program currently works and suggesting that I would oppose any changes that would negatively impact the ability of them to provide care to beneficiaries, including those age 65 and over who have earned their health benefits through their service to our nation. I'm sorry to say, General Stanley, and with all due respect, I wasn't completely pleased with your response, and now the FY12 President's budget request includes a proposed legislative provision that future enrollees would not remain on the plan upon reaching age 65. I'm concerned about this proposal, that it would eliminate access for those in greatest need of care and their ability to receive what's the highest rated health care plan in the military. Let me just shorten up some of my conversation here, because I know you know exactly what my concerns are and what I'm talking about. But I want to reiterate that I'm sure you know by law the government cannot pay more for the care of a U.S. family health care plan enrollee than it would if that beneficiary were receiving care from another government program. So I have a hard time seeing this as anything but a cost shift over to Medicare while destabilizing what is already a very successful program. So I guess I'd like to hear you address that, and also address my concerns that the destabilization of this program, in my opinion, isn't consistent with DoD's stated priorities of improved health management and the continuity of care. I'm just not pleased about what we're doing here in the budget. I understand the importance of cost efficiencies, but to me, I guess it's a little smoke and mirrors and maybe not going to be good for the long-term health care of the people in my state.
Thank you for the question, Congresswoman Pingree. I think as we look at what we're proposing, that each hospital that we're working with, particularly with the Family Health Plan, that we're going to be working very closely with them, because the changes, first of all, may be minimal in some cases, or almost barely perceptible initially as we look at how the Medicare, the funding is worked out, because you really don't want to just unplug and move right into something that becomes a cost shift. At the same time, we're trying to address something that had not been addressed for a number of years in terms of how we, work with the costs and everything. So bottom line is we're going to work with them. And I hear your concern, recognize the concern, and we're going to do our very best to work with them. I'm going to ask Dr. Woodson to address this also.
Thank you very much for that very important question. I think the issues that we need to remind ourselves of is that this is not about taking a beneficiary away from their doctor. They can continue to see the doctor. They can continue to go to the same hospitals. But we pay about $16,000 per member per year in capitated fees to the Uniformed Services Family Health Plans. And it's important to note that they're plans. It's not just about hospital fees, but it's about the money that's also paid to their primary care physicians. Whereas the cost to the government for, let's say, TRICARE Prime is about $4,500, and for TRICARE Standard is about $3,500. Just good business practice in this day and age would suggest that we have to get better value for the dollar. Now, I want to say up front that we consider all of the facilities and providers that are in the Uniformed Services Family Health Plan as great partners. We don't want to lose them. I just think that in these tough times of budget constraints and rising health care costs, we look at contracts everywhere and say, how can we get the best value? The proposal actually will save the entire Federal government about $300 million over about 10 years, because right now, of course, we pay about 42% higher in costs than we would pay under Medicare fees. I remind you also that most of the individuals that are Medicare eligible actually have taken already on Part B. 90% or so already have Part B, because if they were to move or circumstances in their life cause them to shift to other doctors, if they don't take it on at age 65, they pay severe penalties. So the impact to any individual patient is likely to be not that dramatic as well. So it's about being good stewards of public money. It's about preserving money for the future and making sure that the military health system and the provisions under TRICARE remain strong in the future for those who might serve in the future, and bringing equity, if you will, to the benefits for all Medicare-eligible beneficiaries, as well as equity in terms of how we pay all of our providers and hospitals that may serve our men and women who have served. So there are multiple reasons to really consider this, and I think, again, it's one of those modest changes that, on balance, says that we've looked at a number of initiatives to produce efficiencies.
My time's up, but thank you. I'm sure we'll.
And Ms. Pingree, we will get back to another question too. So thank you so much. Very good question. And as we conclude this first round, it's very fitting that we have another distinguished freshman, Colonel Alan West of Florida, who himself has had an extraordinary record of military service. Colonel West.
Thank you, Mr. Chairman, also Madam Ranking Member. To Honorable Stanley, Honorable Woodson, General Schoomaker, General Green, and Admiral Robinson, thank you so much for appearing here today. We talk about the visible injuries that we see coming out of the combat theaters of operation Iraq and Afghanistan, but one of my concerns is the unseen injury, and of course that is traumatic brain injury, TBI. I've had the opportunity to visit with a gentleman by the name of Dr. Ray Krall down in South Florida, who has been offering hyperbaric oxygen treatments to several returning veterans. I've had the chance to sit down with 3 of them, and we have seen some noticeable improvements. About 3 weeks or so ago, I had the opportunity to sit down and have lunch with Vice Chief of Staff General Corelli, and we talked about the opportunities and the options of the hyperbaric oxygen treatment. And one of the things he said that there are some obstacles out there to the implementation of this as a viable treatment for our returning veterans. And so I'd like to know what are those obstacles that are out there, and how can this committee help to, I guess, eradicate some of those obstacles so we can facilitate taking care of our veterans?
Well, I don't think there's anything that the committee can necessarily do for this, Congressman. Thanks for that question. Hyperbaric oxygen is currently an FDA regulated treatment. It's not currently approved by the FDA for treatment of either concussive brain injury or for post-traumatic stress disorder. We have offered through your generous funding any and all investigators out there who are administering hyperbaric oxygen to design and administer protocols that would test and demonstrate the utility of this. We finally undertook those investigations ourselves. We have currently 3 projects. One has been completed at the LDS Hospital in Salt Lake City by an international expert in hyperbaric medicine, Dr. Lynn Weaver. Its results on a non-randomized and uncontrolled study show that hyperbaric oxygen appears safe at this point for patients with moderate and stable brain injury. We currently are awaiting the results of an Air Force School of Aerospace Medicine study that has just been concluded, that is controlled and sham controlled, so that we can see what the effect of the hyperbaric oxygen is against a semblance of that administration of oxygen, but without it. We have yet to see what the results of that, and we're awaiting a more definitive study that will be overseen by the Army's Medical Research and Materiel Command that will include 4 or 5 sites across the country, military and non-military. So the summary of all of this is that despite a series of published and unpublished anecdotes, there really remains no medical evidence that hyperbaric oxygen has a therapeutic role in the relief of symptoms of or brain dysfunction for warriors with post-concussive syndrome or mild traumatic brain injury or post-traumatic stress disorder. And until we have that, we just can't in good conscience provide care, which is quite expensive, without knowing its ultimate safety and its utility.
Well, I guess the thing is, when you sit down and you do speak to some of these young men, as I have, that has said it has made a difference, I think that's some pretty good anecdotal evidence for myself. But, you know, perhaps, Mr. Chairman, we ought to look at seeing if we do need to send a letter over to the FDA and ask what impediments that they're making. But we cannot, you know, take too much time, because every day some soldier, sailor, airman, marine is going through an IED blast, and these IEDs continue to cause much injury as far as TBI. So hopefully we can put a little bit more emphasis and a little bit more speed to this. Thank you very much, and I yield back.
Thank you, Congressman. I look forward to working with you in a joint letter or whatever, and I appreciate your promotion of this issue. We will now have a second round with everyone, a single question. And for me, so often we hear the bad, but there's so much good. And military medicine really has been the best in the world, providing for care of people with brain injuries and trauma injuries. And this applies to the civilian world of auto accidents. These are people who are injured in sports injuries. Additionally, prosthetics. Truly the best in the world now are American military medicine and available to the civilian population. With this, I'd like to know from each of the Surgeon Generals what you have done in regard to cost efficiencies. Can you give us an example of a cost efficiency on behalf of the taxpayers of our country? And we'll begin with General Schoolmaker, the senior person. And then we'll end up with the junior general.
Sir, what we've focused on a lot within Army medicine is standardization of practices, both administrative and clinical practices. It's been widely discussed both in the private sector as well as in government medicine that elimination of unwarranted variation in practices, clinical practices, and administrative practices will squeeze out a lot of waste in the system. We've focused very hard on that. We've also use a business case model for all of our hospitals and clinics in which Commanders are encouraged to target health promotion, health improvement as a way of preventing preventable hospitalizations, ER visits, and the like. And finally, I would say that all of us here, and we commend the Air Force for the lead on this, have embraced the patient-centered medical home, which we think is going to be transformative in bringing into the primary care sector both ready access continuity, because many of our patients seek continuity where we think they're looking for access alone, and a fusion site for behavioral health, for pain management, and many of the other things that we're doing that will ultimately result, I think, in better and healthier people, better and healthier communities, and reduction in costs overall.
Thank you. Admiral?
Thank you very much for the question. In addition to what General Schoonmaker has said, and I'm not going to repeat that, many of the Navy initiatives are along the same lines. We've also taken some internal looks in partnering with the Applied Physics Lab at Johns Hopkins and also the Center for Naval Analysis. We've come through and looked at business practices and also clinical practices in our medical treatment facilities across the enterprise. We're taking an enterprise approach, having industrial engineers come through, look at the orthopedics departments and how we have patient flows at Balboa or at Camp Pendleton, how we have access to care for the patients, how we then work them through our system, how we could do that more efficiently, not only from a patient perspective, but also from a provider perspective. I'm talking about from the corpsmen, from the nurses, from the physicians, from everyone on that team. So we're trying to take an enterprise look at how we can implement that across the board and doing what Eric said in terms of the standardization of practice so that we can reduce the variation. Additionally, in the financial world, and I, not being a financial expert, am blessed to have a really excellent Navy medicine controller who has instituted a great deal of effort at standardization of how we, in fact, do our financial accounting, how we do our audits, and how we look at the financial program's execution. He's been sensational and there's so much more that I can't describe, but he's been sensational and has become a real best practice for not only the Department of the Navy, but also the Department of Defense. So he is being utilized, and a lot of his programs are being utilized there. Those two business practices, that industrial engineering and the way we do our financials across the gamut within Navy medicine, have produced efficiencies and savings and have really made a much better enterprise approach to the way we do Navy medicine.
Thank you. In general?
We've looked at several different things. We actually decreased our headquarters manning to increase the manning back to the hospitals, trying to recapture care. We've looked at standardizing our practice. Part of the medical home was to basically look at support staffing ratios and put some of the nursing staff back into hospitals, again, based on business case analysis to bring the care back in. We've had systems looking at our ORs and at our emergency rooms, basically trying to maximize the efficiency to increase access. We've seen at some of our bases as much as a 40% increase in the surgical cases that can go through our ORs by recapturing care. Under the patient-centered medical home, the satisfaction is up, the continuity jumps from about 40% to 70%, and we end up encouraging the providers to work at the top of their license based on changes to their practice. I would tell you that the partnerships that we're doing are based on bringing care back into the direct care facilities, both for currency and to decrease costs in terms of what's going to the private sector. And finally, the efforts in disease management and case management across all three services are reducing care costs. In fact, in one case out at Hill Air Force Base, we've saved probably $400,000 in reduced utilization by diabetics based on the output and the efforts to try and case manage.
Thank you all very, very much. And Ms. Davis.
Thank you, Mr. Chairman. One thing that I would like to mention is I hope that we'll have an opportunity to look at mental health issues overall, whether or not we're providing the support to encourage people to go into those fields, and also a look at some of the research and development that's been done, and whether or not we're utilizing those dollars well and coordinating those efforts in a way that we really do know what's happened over the last number of years, because we have certainly put a lot of effort into that, and I'd like to take a look at that and see how it's really affecting our service members and their families. But I wanted to go back to Ms. Pinegree's question. I think generally, because the new proposal really could have an impact on our active duty members. And because there is, in the proposal, we're reducing possible payments to sole community hospitals. And those hospitals may, of course, decide to limit TRICARE participation due to the reduced rates. And so I'm wondering, and this goes really, I think, to General Green, whether or not the Air Force has particularly engaged with sole community hospitals outside of Air Force bases to assess the impact of this proposal on the beneficiaries in those communities, and if you're confident that the proposal will not severely impact them. In addition to the concerns that I think a lot of our members are going to have, because there are certain members, communities that are more affected by this than others, we also know that those hospitals that have many cases of disproportionate share hospitals also, even in urban communities, might be affected by this. So I'm wondering if you could address it, General Green, and perhaps others quickly. What do we know about that, and what can we anticipate could be the impact on our beneficiaries?
8 of the 20 hospitals that have over 5% of their income based on admissions are from Air Force areas. And so when you look at those, about 4 of those facilities actually are in the 10% to 15% range for us. We're not the highest, but it is a concern. The reality of the implementation is that we have had longstanding partnerships with these organizations. We believe that the care will still continue to go to these organizations. As you change the payment and bring it in line with payment elsewhere in the country in terms of how we receive care, we believe that the implementation is conservative enough in terms of the basically bringing it online over a 4-year period that we can look at it, work with the local facilities, and if necessary, work with health affairs in terms of any type of transitional changes in payments to make certain that this is sustainable. Our belief is that this is a reasonable approach to try and bring this back in line with what's going on elsewhere in the nation, and obviously it remains to be seen, particularly at these hospitals where it's a large portion or a larger portion of their income. There should be no effect on our beneficiaries because their care would still go to the same areas. It just would be at the rate of payment that's provided at every other site where they might go and seek care if they were out of that area. And so the question is going to be, does it end up affecting the facilities to the point where, despite the long-term partnerships, they feel they have to change the mix of patients? And so we'll be watching that very closely.
Yeah, I would echo those comments. 2 of the 20 are Army-centric, including a hospital in the community that our Secretary of the Army represented at one point. I think everything General Green said applies to the Army as well, and we've been reassured by Dr. Woodson that the financials of this will be looked at very carefully and that we won't erode the relationship that we have with these hospital systems.
Thank you for that question, and I think I want to emphasize that we are willing to reach out proactively to these hospitals to look at their revenue streams and how they'll be impacted. We do have the ability, as the law is allowed, to pay Medicare rates when practicable, and if it turns out a situation that there's a hospital that is providing needed services and there are no other hospitals, adjustments can be made. So I want to emphasize that, in fact, we're going to be proactive about this. We want to be fair about this. But again, we need to, in this day and age, make sure that all of our contracts are really looked at carefully and add value, and as well as quality in terms of the care that's provided.
Thank you very much, and we now go to Mr. Jones.
Thank you, Mr. Chairman. And my question in just a moment will be for you, Admiral Robertson. I appreciated the question by Congressman West. I remember 10 years ago, I think I was briefed by Dr. Harsh from LSU about hyperbaric oxygen as a treatment for our head wounds. And I know I had a conversation a couple years ago. I cannot remember the Air Force officer about where the research is going. And I appreciate your question. I mean, your statement, General Schoomaker, my concern or interest is this, Admiral Robertson. I know that, and I want to thank Admiral Mullen. Quite frankly, I brought this up at a full hearing about a year ago about a hyperbaric chamber down at Camp Lejeune. We do have one at Camp Lejeune, and I believe that they're in the process now preparing to be part of a pilot program to treat Marines down at Camp Lejeune, which I'm very grateful for. Help me understand when, and I understand the need for studies. Please understand, I do realize they are very, very important. But when would the military get to a point after the study by the Air Force, maybe the Army, I don't know that, maybe the Navy as well, when do you get to a point that the study says, and I'll tell you why, and then I'm going to let you answer. I've called numerous moms and dads whose sons and a couple of daughters have been in the hyperbaric chamber treatment. One that really sticks with me, and I want to use this before, and then you answer, please, sir. I called Colonel Bud Day. He, Marine, won the Medal of Honor in Vietnam. I called him, and he told me that his grandson had a severe brain injury from Iraq, I believe, at the time. And he was just not satisfied with the treatment. And at his own expense, he sent his grandson to LSU, to Dr. Harsh. And I never will forget, Colonel Day said to me, he said, I'll go anywhere I need to go to testify that this treatment has given my grandson a quality of life that he would never have had if he had not had the hyperbaric treatment. So now, this was the question I had just a moment ago. When do we get to the point that we say, meaning the Department of Defense, that this protocol does help, it does work?
Congressman Jones, thanks for the question. This has been, for me as Surgeon General of the Navy, a 4-year question. We have looked at hyperbaric oxygen, and Dr. Harsh, who has been at several meetings, and I've met him many times and looked at his results. We've invited him to come through and participate firsthand in our double-blinded studies so that we can get away from the anecdotal results of individual patients, families, and other anecdotal lessons, and we can get down to what we have to have from an objective and a definitive way so that we can base clinical practice guidelines, both for the military health system and also for the private sector. We need to base those therapies on objective clinical data that cannot be influenced by opinions of people who have benefited, but we can't prove that benefit in a scientific way. So we need to employ a scientific method. What we have done, and I can say that in my 4th year as Surgeon General, we now have studies. We're now beginning to produce data from competent studies that look at, number one, hyperbaric oxygen seems to be safe. So I think that is a clear improvement in terms of our knowledge. And now we need to go and look more deeply at the Air Force study, and that study has been completed, but the analysis has not been done. So I think we're very, very close to getting more data. I think when we can get some studies on the record that actually look at the efficacy of hyperbaric oxygen therapy, I think at that point we can simply say that is an effective treatment. It is not an effective treatment, but it is a treatment that can be utilized in complementary medical ways so that people who may benefit from it can use it. It's certainly not going to harm them. We will have an array of answers. I think we are literally months away from getting there, but it normally takes, and this is one of the issues with medicine, it normally takes time to get to where we need to be, and we have to base it on a scientific method in order to keep from having everything become a clinical practice guideline, things that are not proven. So the scientific method has been utilized in this way.
Thank you, Admiral. Thank you, Mr. Chairman.
Thank you very much. And next we go to Ms. Pingree of the great state of Maine.
Thank you, Mr. Chair. Thanks for the opportunity to discuss these issues with you again on the second round. And I just want to say again, I understand how well you are all doing your job and the importance of all of you looking for cost efficiencies in what you do as we face a difficult time with the budget deficit and also where there's a lot of examination of the military budget and looking for places where we can cut. And maybe my first comment really is more to my fellow committee members than to all of you, but I might see more places to cut the fat in the military budget than others of my colleagues, but I am deeply concerned that we're going after medical care for both our active duty personnel and our retirees when I think there are other places to make more effective cuts. So I know you have to do your job and look for those cuts, but almost everything that's before us today, either myself or one of my colleagues has mentioned a concern about, whether it's the changes to TRICARE, how we're going to deal with some of our sole community hospitals. I have 2 in my district. There are 4 in our state of only 1.2 million people. In a state where we have almost 1/5 of our citizens are either active duty or retired military. So there's very big dependence on this system in our state, and I'm worried about that particular program. So for me, many of the efficiencies that you're talking about are going to reduce the level of medical care to the people who have served us, to whom we have made a huge promise, and there is going to be, I think, a reduction in the services that they receive. So I know you have to do your job, but I don't like it, and I don't think it's all necessarily good. And the only other program that hasn't been brought up today, but I might ask you to comment on, is the pharmacy copay. I've seen a little bit about that and know that some of the copays will be reduced through using mail order pharmacies. I have concerns about that as well because I do believe that people get better care when they go directly to a pharmacist in their community. It's where we catch a lot of redundancies or problems with the medications that people are taking, particularly with retirees. So in my opinion, having to go to mail order to get your pharmaceutical products is not necessarily always good treatment or good service. And one of the things I might ask is how much the department is doing to negotiate for better prices with the pharmaceutical companies and bringing costs down in that way as opposed to this other option. That's my question, if you've got any comments about that.
We continue to have efforts to negotiate with pharmaceutical companies. I think, in fact, that mail order advances care because there's a large percentage of retail prescriptions that are never picked up, and there's breaks in terms of the supply of medications. Our proposal not only reduces the cost, but ensures timely supply of medicines. And, of course, linked with our concept of the patient-centered home, they have a team of healthcare providers that can counsel, coach, monitor the medicines. We have new electronic databases that highlight medication interactions and notify practitioners of medications that may be unsafe. So I think there are a number of things that we're doing that are going to enhance the quality of care while reduce the cost and provide a better service for the beneficiaries.
I appreciate your perspective on that. That's useful information in thinking about the program. Back to the question of negotiating. Is that an active activity that goes on today to negotiate for cost cutting? We still continue to pay some of the highest prices in the world in this country for prescription drugs. And I know the military has done a better job at bringing down the cost, but I wonder how engaged we are in the process and how much resistance there is to it.
Ma'am, I'm told that that's a commodity that's managed through the Defense Logistics Agency and the center in Philadelphia, and I'm told that the Department of Defense has some of the most favorable cost profiles of any organization in the United States because of leveraging volume.
Great. I'll take up that issue with them. Thank you again for your answers today.
Thank you, and I share your appreciation of local pharmacists too. We'll conclude with Dr. Joe Heck.
Thank you, Mr. Chairman. And not to belabor the issue, but I'm going to go back to TBI. First, I appreciate the Surgeons General and the academic rigor with which they're reviewing the HBOT issue. And please, I encourage you and implore you to keep that academic, rigorous approach before we make a determination on its application. No matter how that turns out, no matter what treatment process we have in place for TBI, my biggest concern is identifying the soldier, sailor, airman, Marine, who has TBI. Based on my deployment to Iraq, when young guys were getting their bells rung so many times that they had the MACE card memorized, no longer became a valid screening tool because they knew the answers before I asked them. When I came back, it spurred me to write my Joint Forces Staff College paper on TBI, entitled Rethinking the Treatment Paradigm, and that was 3 years ago last month. I don't think we've come that far in 3 years, as far as we should have, in being able to recognize folks suffering from MTBI. I know there was an initiative underway that everyone pre-deployment was supposed to get a cognitive assessment, the ANAM or equivalent. Where are we in that process in making sure that everybody before they deploys has a baseline cognitive assessment done so that we can find the small changes when they come back? And then specifically, going back to my heart of hearts in the reserve side of the house, it seems it's the reservists that are getting lost to the follow-up. They get home, they're irritable. The spouse or family member saying, well, he's just reintegrating. We got it, this is his reacclimation process. 3 months later, he's still irritable. And then somebody starts to think, well, maybe it's something more than just he's been gone for a year. But by that time, we've lost 3 months of intervention. So again, the status of the cognitive assessment pre-deployment, and what are we doing to make sure we don't lose reservists to follow up, or it just gets brushed aside as they're just getting reintegrated or reacclimated.
Let me take a stab at, as I might, Congressman. First of all, I think we've come a long way in the last few years, especially with the publication, as was referred to earlier, of the decision-type memorandum. Earlier in the war, as you may recall, we had clinical practice guidelines on the battlefield, but they were not mandatory in their application, and we failed to recognize that the soldier, the Marine, the sailor, the airman who was actively engaged in battle and was part of a team was very reluctant to leave formation, and would celebrate their survival of an IED, but then would go right back in the fight. We now have a mandatory screening tool downrange. In our recent trip to Afghanistan, we looked at its application and how well we're complying with it. We're seeing very good acceptance by combatants, by their small unit leaders, all the way up to General Petraeus himself. And with resiliency centers such as the one that Admiral Robinson mentioned, and we have 7 in eastern Afghanistan and southern Afghanistan, we're seeing a rapid turnaround. So we have mandatory screening of a clinical diagnosis only, as you know, at this point, and then we apply tools like the ANAM, the Automated Neurocognitive Assessment Module, to do longitudinal tracking of whether they're recovering. We've done studies now with the ANAM downrange with fresh casualties to be able to know that as a screening tool, it's insensitive and nonspecific. It misses about 1/4 to 1/3 of those who are concussed, and it includes about 50% of people who aren't concussed. We're doing a head-to-head evaluation between the ANAM and the IMPACT tool that the National Football League uses and many high schools use right now. But you're absolutely right. Right now, we have no single definitive test for the diagnosis other than a clinical diagnosis of concussion, but we're being very much more aggressive. And right over the horizon, we see biomarkers and other tools that we think will be useful in that.
Okay. Thank you very much. Admiral, did you want to add to that?
I think that General Schoonmaker was very comprehensive. I'll just add one piece. We also have the NICO and the Defense Center of Excellence that is devoting a great deal of research efforts, both in the basic science areas and in the areas of trying to understand how we can diagnose and then how we can assess and treat traumatic brain injury. Now, I'm not going to mix the two, but PTS is also there, and it's on a continuum, but I'm going to stay with the TBI. So I think that we're not only doing the in-theater assessments, we're reporting the data, we're actually compiling data, reporting it. I think that General Schoonmaker has emphasized the concussion part, because concussion as a clinical diagnosis is at least something we can diagnose and follow, as opposed to just TBI, which becomes a little bit more difficult to define and understand. But with the ANAM and with the MACE, with our professionals trained, with the Uniformed Services University Deployment Psychology group, training our professionals, just-in-time training as they go over into theater, and with adequate data, having the concussion restoration centers, multi-comprehensive teams, I think we're going to get at least a look at who's been involved, how we can do a longitudinal look at them, and make sure that we can at least follow them, even if we can't do a lot in terms of understanding how it works now. We don't understand this completely, but we're not going to let it go.
Thank you. And I'd like to again point out how much we appreciate all of you being here today, particularly General Schoolmaker, Admiral Robinson. We want to wish you Godspeed in your future endeavors. And again, I think it's been so illuminating, and we want the best for our military families, and veterans. At this time, we are adjourned.